Hi, this is QD Clinic, brought to you by RheumNow.Live. I'm Jack Cush with RheumNow. QD Clinic, as in daily cases from the arthritis clinic. In these series, we discuss interesting things that happen on a daily basis in the clinic that are things that we could talk about that I'm sure are happening to you. So my case today is in fact about a 78-year-old rheumatoid arthritis patient who, and the question is, or the title would be, I'm having surgery. And the question is, what do you do with arthritis medicines in someone who's going to have surgery? Specifically, a rheumatoid patient on a biologic, on methotrexate, or any other kind of DMARD, on steroids, on nonsteroidals, aspirin, etc. So the rules are pretty simple. Most people do this wrong. Surgeons are always doing this wrong. They think that if you're on a biologic, you're going to impair wound healing. There's no evidence of that. Wound healing is largely related to risk of infection. Wound infections, which all patients are at risk for, especially patients on steroids, are what cause wound healing problems. So you want to lower infection risk and whatnot, but the research that's been done on it, there's been a lot recently, says a few things. Number one, stress doses of steroids are no longer necessary. They don't even work. If you're on steroids, you continue on the same dose the day of surgery, the day after surgery. Stress dosing is no longer needed. Number two, aspirin, nonsteroidals, aspirin should be stopped a week before. Nonsteroidals should be stopped 5 to 7 days before, and you can resume a nonsteroidal again when the surgery's over, maybe the day after surgery. As long as there's no bleeding issues or renal issues, you can resume the nonsteroidal quickly right after surgery. Number three, DMARDs. DMARDs should be continued throughout surgery. And there's a lot of reports that say patients can continue on methotrexate, Areva, again, some of these really being Areva, a really long half-life drug, sulfasalazine, hydroxychloroquine, azathioprine, tofacitinib, all of them. There's really no reason to stop an oral conventional DMARD in someone who's having surgery. However, surgeons will wig out over this. They'll lose their mind, they'll hang up on you, they'll think you're a nut job. So what do you do? I mean, honestly, if the surgeon is willing and will take your advice, continue the DMARD and don't stop. If you think the surgeon is really skittish, tell them stop the DMARD a week before and start it a week later. No one's going to be harmed by that kind of mentality. But again, you do need to know your surgeon and who you're dealing with and whether they'll take your advice fully or not. And then the easy part is the biologic. The rule is hold the biologic for one dosing interval. So etanercept, be off for a week. Weekly tocilizumab, be off for a week. Monthly tocilizumab, be off for a month or actually maybe a few weeks. The idea is you don't want to give have the surgery when they just got their dose of a biologic. You didn't get a Remicade infusion or any kind of infliximab infusion on Monday and Wednesday having a total hip replacement. You should wait a week or two. You want to be on the nadir as far as blood levels. But you don't want to be washed out, because research shows that when you have them off for a really long time and you wash them out, guess what? They flare, inflammation takes over, and risks go up. Bad outcomes, including infections, go up. So it's okay to be on them, be off them for one dosing interval, off for 1 week, 2 weeks. Usually works for most patients. You could say 4 weeks for everyone, and that would be a little bit of a risk, but I would say really 2 weeks for everyone would probably be the smartest advice if you had one rule. But the rule by many societies is one dosing interval, and you restart when the sutures come out. So assuming there's no complications of surgery, there's no bleeding, there's no wound infection, and the sutures are coming out, boom, you start the biologic right away. The biggest mistake made is when patients do not have their biologic or DMARD started until 6 months after surgery. And guess what? By then, the patient's a mess, and you've contributed to the failure of the arthroplasty, failure of whatever major surgery was done. Do these rules apply for dental surgery, eye surgery? No. But then again, there are no good rules for dental surgery and eye surgery. There I would hold the nonsteroidal and the bleeding potential. I would otherwise not change the use of a DMARD or a biologic. I would continue that for most eye procedures, unless they're going to be in the OR for 5 hours. Then what I just told you, those guidelines are for major operating room kinds of surgery. That's it for this week at RheumNow Clinic, QD Clinic. Tune in tomorrow for another one.